Right.
Well, good afternoon, everybody. Looks like it's just a little after 1. I know some folks are still coming in, but I think we should get started. We've got a lot to cover today. So they've given me a script so that I can help everybody navigate the webinar. So I'm going to go ahead into reading mode here. If I sound more plastic even than normal, I apologize. Good afternoon. Welcome to today's VHCIP Payment Model Design and Implementation Workgroup meeting, as well as today's webinar, Deep Dive into Vermont's Year 1 Medicaid and Commercial ACO Shared Savings Program results. For those participating via the web, this is Andrew, a co-chair of this workgroup. We'll start our webinar today with a bit of regular workgroup business, then jump into our presentations. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Great. This is slide number 2. Yeah, on the left side of this slide, we've included a screenshot of the webinar's attendee interface, the control panel. You should see something that looks like this on your own computer's desktop in the upper right corner. You're listening in using your computer's speaker system by default. If you would prefer to join over the phone, just select telephone in the audio pane, and the dial-in information will be displayed. We've set aside some time for discussion and questions at the end of today's presentations. I just want to stick on that point. We've got a lot of material here, and I know there's going to be a lot of discussion, so we're going to go through all the material first and hold questions and comments, both from folks in the room and on the phone, until we've gotten through the material, and then we'll try to leave as much time as possible for questions. If you're on the phone, you'll have the opportunity to ask questions and make comments using the Raise Your Hand feature. During the Q&A session, click the raised hand icon to be unmuted. Staff will then call on you to ask questions during our moderated discussion. And I'm just going to ask everybody now, and I'll remind you later, let's keep our questions and comments brief and to the point, and try to just take one question or one comment, because I think we're going to have a lot of discussion. I want to make sure everybody can participate. The event today is being recorded. The slides and recording will be posted to the VHCIP website. You'll be notified when these materials are available. At the end of the event, you'll be redirected to an evaluation survey. Please complete the survey. We really value your feedback. And with that, we'll turn the meeting over to Joelle for roll call.
Okay, good afternoon, everyone. I can see the folks who have dialed in on the webinar, so I have been trying to take note of who has come into the room in person and who has already signed into the webinar. So hopefully this will be fairly quick. And I may not call everyone's name. If I already see someone representing the organization, as we have multiples, I may not call out a name. And if you're in the room, I think I know everyone here, so I think I can take care of that. So from Northwestern Medical Center, I don't see anyone logged in. Is anyone on the phone who hasn't logged in? Okay. And from VAS, Mike Del Treco, I don't see. From SASH, Kim Fitzgerald, Molly Dukin, or Stephanie Hartsfield. Okay. From the VNAs, Peter Cobb or Beverly Boguet or Michael Counter. Okay. I am checking. And Bard Hill, are you on the phone? I'm not seeing a login here for Bard yet. Okay. I think to be on the phone, I'm pretty sure they have to log in. Oh, you clearly have a quorum today.
All right.
Thank you.
Should we go ahead then? All right, so we can, did everybody get a chance to review the minutes? They were distributed in advance. Any comments or questions? All right, seeing none, we can entertain a motion to approve the minutes. Oh wait, we do this by exception, right?
We can do, yeah, so if someone would like to make a motion to, preferably in the room, to make a motion to approve the minutes by exception.
So moved.
Thank you. Thank you. Okay. What we will do is those on the phone on the webinar, you can click the raise your hand button to approve the minutes. If you need to abstain, you could just type in the chat window, abstain, and I will be able to see that and record anyone on the webinar who needs to abstain. Anyone in the room, just let me know if you need to abstain from the voting of these minutes. Otherwise, all in favor, say aye.
Aye.
Raise your hand, as it were, literally or figuratively. And then any abstentions in the room? Okay. One. Gotcha, Julie. Thank you. Any abstentions via the webinar, please just type in the chat box there where it says type message here. Just type abstain, and I will be able to record that. And hearing and seeing none, it looks like your minutes are approved. Thank you. Thank you.
Okay, if there's no other business, then we'll get started right away with the presentations. We have a lot of time on the calendar for this today. I think we're looking at about 40 minutes of presentation time, which should leave us 40 minutes or so of question and discussion time.
Agenda items updates, which is totally fine.
I am sorry. It's not on my script. Would you like to give some updates?
I would love to.
Okay.
Thanks for asking. So just wanted to update folks that we did indeed submit our Performance Period 3 operational plan and budget. I'm sure all of you have read through it. It comes in at about 600 pages of the best writing that we have, some of which is intentionally obscure and vague. So please let us know if you have any questions. If you find any typos, don't tell us. We just don't want to know that. But we submitted that to the feds. We also hosted the feds in the early part of May and had a pretty great federal site visit. It was a little bit more forward-thinking than those in the past. So really the feds are thinking about sustainability and next steps for Vermont. And so we were able to have some really great conversations with them and a lot of positive, constructive discussion. Next steps are that we are waiting for them to approve the operational plan as well as a whole bunch of other financial budgeting things. They have yet to come back to us with questions, knock on wood, so that's also a good sign. I'm not going to go through the details of the operational plan because it is rather lengthy. If anyone has read it and has questions, please let me know, or if you have questions later, please let me know.
All right, now we'll move to the presentation. So I think we have 3 presenters today, at least 3. I hope I'm not missing anybody. Kelly Lang from Blue Cross Blue Shield of Vermont, I think is going to start us off, and then Kate Enrick from CHAC, and finally Alicia Cooper from DIVA.
Ricky from Health First. And Rick. Kate from CHAC, Ricky from Health First.
Having a bad day. All right. Kate from CHAC. All right, let's just start the presentation. A reminder that we're going to hold questions to the end. All right, so we've got about 40 minutes. We'll start off with Kelly. Thanks.
Hello. For those who don't know me, Kelly Lang, Director of Delivery System Innovation and Contracting at Blue Cross. Worked with Richard extensively on the commercial ACO pilot that is currently in year 3. We're closing out year 2, but we're now presenting year 1's pilot performance. So Richard will jump in as I go through. The data here is a summary of financial and quality information that's been validated by Blue Cross, and then the Fluent is the vendor who's helped the Green Mountain Care Board go through this. So the first 2 slides are to look at the commercial year-end results for all 3 ACOs. The first slide you have here, which is labeled for those of you on the phone, sorry, slide 3. The aggregate result is if you put all our financials together in dollars, not on a per member per month. That's the difference in the next slide. How the ACOs performed, just level setting for year 1 and year 2. Our target, so the target aggregate or target PMPM was based on the medical spend portion of our premium for our members. So these are qualified health plan members and that are subject to this pilot. And the target is based on what portion of our approved Green Mountain Care Board premium is for medical spend, with some technical changes for high-cost cases. This is only medical, does not include pharmacy. And There's other couple carve-outs, but it's most of our medical spend. So we take that, and for year one, use the final approved rates, and then, and I'm now actually on slide 4, which I think is a better way, in my opinion, looking at the results of out of our target, or excuse me, approved medical spend. We set a expected and target per member per month. The expected is what we predicted would be in our medical spend on our premium. The target is something below that based on Medicare ratio that the ACOs, if they've reached, could achieve greater savings, shared potential. So this is where the ACOs perform. CHAC, One Caring, Vermont Collaborative Physicians, keep messing up, sorry, Health First, also known as Health First. The lives here are divided into member months, because if a member was part of the ACO for only a couple months, only a portion of that time would be used to calculate the expected and target. All 3 ACOs came in above expected, and that's what that number is, not from target. Within ranges, I'll go into a little bit of what we're looking into of all of that, but there was no savings earned. This was for the first year and 2. This is a new population and qualified health plan, complete new benefit setup. This was not something where Medicaid has had a population for the time before the pilot. This was a brand new population, brand new benefits, working with the actuaries, with the Green Mountain Care Board, and with our actuaries' best estimates. So they were set in a way that everyone approved, but we were also above on our overall book of business, non-ACO, so we saw that's in line with our Blue Cross book of business for that population.
I just would mention, Ms. Richard, that the way this was set was agreed upon in the ACO standards for the commercial shared savings program. So there was a very detailed, lengthy discussion prior to the setting up these rates and targets.
And everyone acknowledged, and this is where we worked very hard to make Medicaid and commercial very similar programs, but this is one due to the benefit structure, which is something Medicaid doesn't have so much to deal with, and the new population we knew might be off. So this chart, what it goes through is shows where the ACOs performed, and then if there was potential for savings, our quality gate is different than Medicaid. It's what they would have received out of a portion of their shared savings. It has a lot of underlying complexity. There's 2 actually areas that could receive savings and share with the ACO, but this is what would have been the overall calculation based on their quality scores, which we're going to go through. I just want to stop on this for a moment in terms of, I've noted this is year 1 and 2, the same type of target evaluation and expected would be the same, and we're finalizing that right now. And there has been improvement. We still have the numbers final for year 2, but the target for year 3 is actually, we're proposing to be based more on the population, not on that has been in each ACO. So taking the experience, the providers, which is actually what a lot of ACOs have done, and now that we have experience, it's still tied to the premium and what the Green Mountain Care Board approves, but it's related to that actual ACO's experience. But that has not gone to the Green Mountain Care Board for final approval yet, and so we don't have those final numbers. So we go to the next slide, please. So this slide, for those on the phone, or well, actually on the webinar, these are the payment measures and how the 3 ACOs perform. We have similar payment measures to Medicaid, but ours are a little different. Some things, and I would classify year 1 and 2 as learning efforts and learning curve by both ACOs and all the payers. We found out of these payment measures we've had issues with small denominator, which we all expected, but we really obviously saw it. And so this for CHAC and VCP, one of the measures was not applied, and the ACOs and Blue Cross agreed upon that just to remove it from their overall points they could obtain and modify the results, basically not penalizing them. And because OneCare has a larger population, they were able to be included in the measurements. And the measurements are based on HEDIS requirements, so they're standard, and we look to national benchmarks. So these are how all the 3 ACOs perform. One thing is we're also, some of these measures getting into this slide and the next slide require 12-month enrollment, which if we recall in 2014, which that's the year we're talking about, qualified health plan enrollment could actually be delayed through April in the Catamount transition. It wasn't a 1-1 start. So this is really only a partial year, but still really good learning efforts by the ACOs and Blue Cross in this, which have created the benchmarks for where we are.
We're working now with Lewin to develop the second-year report, which will be compared to the first year. So you'll be able to see if there was any improvement or fallback on the quality measures, how they performed on the expenditures relative to target, and also compared to year 1. So I think it'll be much more informative for year 2.
Yeah, the same would go for the financials and the quality are being finalized, and that's really when we could start comparing apples to apples because you have more experience. We still wouldn't have a full year experience in setting that target, just how you set rates, but we have more. So, and the ACOs and Blue Cross have had more time to work on our process and working together, which improves throughout year 2. So this is a summary tying back to the financials on the impact of payment. And so Vermont Collaborative would have gotten 100% of their portion, OneCare 85%, and CHAC 75% of the potential shared savings if that had been achieved. And a summary point that were called out, and I agree with you, and kind of this was something just to give us more for looking at 2015 and then next year for the 2016 data. We had some good results above 50th percentile, above 75th percentile, but these are actually only on a few measures if you think about it, so there's still room for improvement, especially at the 50th, so get higher. And then there's variation among the ACOs. What is partly that we're looking at, the ACOs have very different populations, I shouldn't say very different populations. Depending on where their providers are across the state can, much like we've seen in other programs, can lead to this different profile of the patients that are part of their panel, and so quality may be, that may be one difference between the ACOs. And then the denominator issue, we're actually looking, do we combine some measures among all 3 ACOs? One thing we're looking at going forward, just because we're dealing with small populations here. And these are the reporting measures, which I find just as important. They would not impact the payment if there were savings, but these are very informative, and a lot of these link then to some of the more population health goals that we'll look at as a state. These are still standard measures, but looking at where, again, the ACOs land, and you'll see on some of them no benchmark as we try to look at these as 25th, 50th, 75th percentile. That's where now having a year's worth of data will give us some benchmarks, and we'll look at going forward. Some of these just don't have national benchmarks, and we knew that going in there. And then, again, a lot of the same strengths and opportunities from the reporting measures. The big one, and the ACOs can speak to this, but we're part of it in terms of our facilitator, is really the collaboration in collecting clinical data. And that'll go forward in year 2. There have been presentations about, this is a lot of work going into offices or going into EMRs, getting all the data, so how we can all work together. That's been, I would put it actually, it's still an opportunity. There's still a lot of room for improvement, but working together between the ACOs and then as much as we can in terms of our data facilitate that. Lack of benchmark we talked to, and then the electronic data capture, which I just referenced, is, I would say, the 2 biggest opportunities going forward. And some things we're looking at is just, what measures going forward, and year 3 are set, but might be applicable. And next slide. That's all on ours. I just, as a summary, the year 2 work is very similar in terms of what we now are going to compare it. The year 3 work, we're working at, again, the new target, which is more population-based in terms of the ACO, more specific. I actually think that'll show a lot of improvement in terms of comparing the ACO to itself. And then also continuing on working together in terms of supporting the care design of the ACOs, supporting what we want to look at for data. It's still a new process in terms of where there's gaps, where we can have areas of improvement, and looking at other clinical information in terms of the population. Anything to add, Richard?
I would just note that the year 3 calculations have been discussed with the ACOs and Blue Cross and Lewin, and there just seems to be, I think, general agreement to go forward with this new approach. There's a couple unanswered questions, but basically everyone is in agreement that that makes sense. I think the year 1 was a learning year for everyone. Year 2 will compare year 2 to year 1, so that will be more informative. And then year 3, I think, starts to get us to where we want to be if we're going to go into an all-payer model or other types of reimbursement. So we'll have a lot of experience under our belt in that 3-year period.
Great. Thanks so much, Kelly. I appreciate it. I think next up then would be Alicia. Yes?
Yes.
All right, great. From DIVA.
Yes. Good afternoon, everyone. I'm Alicia Cooper. I'm with DIVA as a part of the team that's been implementing the Vermont Medicaid Shared Savings Program for the last couple of years. A lot of the content of this presentation will be similar to what Kelly just talked about in her presentation of the commercial results. But in addition to the results that the Lewin Group produced as part of their year 1 final reconciliation, staff here at DIVA and our partners at Burns & Associates have also helped us to do some additional analyses to help us understand some of the underlying pieces that went into the results for the 2014 performance year. So I'll speak a little bit about that as well. For the sake of time during today's meeting and to make sure we have enough of an opportunity for discussion, I won't spend too much time going into a lot of detail during the presentation, but I will point you to the report that was distributed with the materials for today's meeting that goes into a little bit more detail and is available for all of you to reference at your leisure. As Kelly referenced, there were some slight differences in the Medicaid and commercial program methodologies, in particular as relates to calculating the financial piece. One of the challenges that Medicaid did not necessarily have when setting its targets was sort of a lack of historical experience. We did have a population of Medicaid beneficiaries who would have been considered eligible for attribution to an ACO during the baseline period had such a program been in place. One of the complexities that we will talk about a little bit that threw in a certain amount of uncertainty was the 2014 Medicaid expansion. So we'll spend a little bit of time in particular talking about some unique population segments within the overall population eligible for attribution. On this first slide, we have a summary that is comparable to one of the slides that Kelly showed earlier with the 2014 program results. Both of the ACOs that were participating in our Medicaid Shared Savings Program in 2014 exhibited lower per member per month expenditure for their attributed members than was expected. As a result of this and as a result of meeting their quality targets in the first year, both of the ACOs were eligible to share in a portion of the savings. And as you can see in the bottom line of the table on that slide, both of the ACOs received about $3.3 million in shared savings program payments as a result of the 2014 performance year. So once the Lewin Group was able to provide us with that information, we spent the last several months doing some analyses in addition for the purpose of trying to understand some of the things that went into those results. In particular, we broke our analyses down into 2 areas. The first was to understand differences in unique population segments within the overall population that's eligible for attribution.
And we also wanted to take a look at some changes in utilization and expenditure across different categories of service and different groups that were eligible for attribution as well. So before we can talk a little bit more meaningfully about some of these population segments, it's an important thing that we all have a common understanding of the methodology that the Vermont Medicaid Shared Savings Program uses to attribute Medicaid members to an ACO. When we consider our overall Medicaid population, those who are considered eligible for attribution are adults and children with at least 10 months of Medicaid eligibility in the program year who do not have additional sources of coverage. So we exclude anyone who has Medicare coverage in addition to Medicaid coverage, anyone with other sources of commercial coverage or third-party coverage, and we also exclude individuals who don't have a comprehensive Medicaid benefits package. A good example of that would be beneficiaries who only receive pharmacy benefits through Medicaid. Our attribution is primarily based on a beneficiary's relationship with their primary care provider. So we can identify that through one of two ways, and we call this sort of the two steps in our attribution methodology. The first thing that we look at is claims data from a historical time period. So if we see in the claims data that an individual has received primary care services from a primary care provider who is participating in an ACO, we can use that relationship to establish ACO attribution. In the event that an individual doesn't seek any primary care within a program year, we can attribute them based on their PCP of record in the Medicaid eligibility file. So that allows us to attribute more members to an ACO than those who are just utilizing services. But it does leave a certain amount of uncertainty about where folks will actually be seeking care if they do seek care during the program year. As I mentioned previously, another interesting element to consider as we look at the 2014 results is the 2014 Medicaid expansion. This had an impact on the overall Medicaid population that's considered eligible for attribution. So this slide shows a breakdown looking at 2012 and 2014, the numbers of individuals who were considered eligible for attribution. And we break it down by whether those individuals would have been attributed to OneCare or to CHAC, or whether they would have been considered otherwise eligible for attribution but aren't attributed because their PCP relationship is through a provider who isn't a part of one of those two ACO networks. You can see, looking from 2012 to 2014, the number of individuals considered eligible for attribution increased by about 20,000. This is also interesting because there was a lot of uncertainty nationwide when contemplating Medicaid expansion about how utilization patterns would look for this group of individuals. There was the possibility that these folks would have a lot of pent-up demand for services. They might be in more need of services, and that might result in them being particularly high utilizers of the healthcare system. And there's also the possibility that they would really access the system pretty minimally in their early months of eligibility, and that there would therefore be pretty low utilizers of the healthcare system. And that degree of uncertainty about these 20,000 newly eligible folks, that's 20,000 who would be eligible for ACO attribution, the overall number was larger. Made it a little bit difficult for us to say anything with certainty about what historical experience for Medicaid beneficiaries in the baseline period would mean for the utilization of these folks in 2014. So now if we combine those two things, we combine whether or not they were attributed based on actual utilization or based on their PCP of record, with whether or not folks had eligibility that preceded the 2014 expansion of Medicaid benefits, or whether they were newly eligible for Medicaid, You can see that we break it down into these sort of 4 different groups that are helpful for looking at some more detailed comparisons. As you can see, in 2012, only 2 of those groups really apply because we don't have any groups who were considered expansion eligibility. But then in 2014, we have 2 new groups, so it makes it difficult to really compare their experience to anything in the past, but we can compare them to reasonably comparable groups in the original eligibility category. So on this slide, we can take a little bit of a look at what those 2 categories do for changing our population from 2012 to 2014. So in the figure in the darker green color on the left, we see the impact of being attributed in 2012 and then having the added folks who are eligible through Medicaid through the expansion in 14. So pretty much we're just seeing population growth across the board in the group that would be eligible for attribution to check, the group for attribution to OneCare, and then this other group would be otherwise eligible for attribution. So overall, our populations are getting larger, and that new group is accounting for approximately 20 to 25% of each of those group populations. On the figure on the right in the lighter green, we can see what happens when we look at the proportion of beneficiaries who are attributed through that first step or based on claims experience versus those who are attributed through that second step, which is their PCP of record. And so you can see going from 2012 to 2014 in each of those groups, check, OneCare, and other, the proportion of individuals who are attributed based on the PCP of record and not any actual utilization in the performance year increases. So this is the slide where we kind of put all of it together and try to take a look at all 4 groups in one place. Again, you can see that in 2012, we're only really looking at 2 groups. Those are the ones that are represented by red and white in the figure at the bottom. And then in 2014, we have our 2 new groups, which are represented by a darker turquoise and a lighter turquoise. That just shows how the population changes in composition from 2012 to 2014. So on this slide, we've got a few animations, and thank you, Christy, for obliging. If you click the first one, yep. So here we can start to look at the per member year expenditure in each of these different groups. And we're trying to color code it so that we can compare the right groups across years to make it a little bit easier for the presentation. But in these first highlighted boxes, the red highlighted boxes, we're comparing those individuals who are attributed through step 1 or through claims experience and who have original Medicaid eligibility. So they were eligible previously and they still are eligible in 14. As you can see in this group, sort of across all of the ACO categories, we're seeing that expenditure went down from 2012 to 2014. Now we bring in the next group, which is individuals who are attributed through that second step or based on their PCP of record. These are also folks who have original eligibility. And once again, we're seeing that on average, per member per year expenditure is going down from 2012 to 2014. And so now we have 2 more highlighted boxes in blue. These represent our 2 new groups for the 2014 year. We don't really have a 2012 analog to compare them to, but we can kind of look at how the step 1 attributed folks or the claims attributed folks compared to those who were claims attributed with original eligibility. And you can see that these folks are actually more expensive. They're more expensive than their peers in 2014, and they're also more expensive than folks in 2012 who were attributed based on claims. This is likely that sort of part of the expansion population that did have pent-up demand for services, the ones who were utilizing services more intensively in 2014. On the flip side, when we look at that Step 2 attributed expansion eligibility group, you can see that they have much lower expenditure than either the Step 2 attributed folks in 14 or the Step 2 attributed folks in 12. And so that's sort of the other side of the coin, where we're looking at folks who really didn't use much in terms of healthcare services in the total cost of care suite of services in the 2014 performance year. So on the whole, we're seeing, you know, the Step 1 folks and the Step 2 folks through the expansion who are all looking less expensive than their peers in 2012. And then there's that sort of smaller subset of the overall population that was, in fact, more expensive. But on the whole, we're seeing a decrease. So some other ways of thinking about the results for 2014 that guided our analysis were to look at some of the overall eligibility categories that we use when talking about the shared savings program. We typically break it down into a more general adult category, a general child category, and an aged, blind, or disabled adult and child category. And these are largely broken down for the purposes of understanding the different expenditure patterns in these three population segments. But it's kind of interesting to look at how their expenditure patterns have changed from the baseline period to the 2014 period within these segments, because the consolidated adult group is the one that was most impacted by expansion, and the consolidated child group is the one that's least impacted by expansion. So on the slide that's showing now, you can see three figures. The one on the left is a statewide group that's representative of all individuals considered eligible for attribution. And then the two on the right are for CHAC and OneCare. And you can see that pretty much the patterns are the same for all three figures. We're looking at general trends of decline across the three baseline years and going into our 2014 performance year for the populations that include more of the adults. And then we're seeing a slight increase in the population that's children only across the board. I think that's all I want to say on that one. And then that takes us to a related figure, which helps us look at individuals who had no expenditure in either the baseline years or the 2014 performance year by those three eligibility categories in the total cost of care suite of services. So basically, these are individuals who are, for the purposes of describing the program, not utilizing services. They might be utilizing services that are also offered by Medicaid that are outside that total cost of care, but for the purposes of this demonstration, we'll just say that they're non-users. Again, we've got the statewide figure on the left, and then the CHAC and OneCare figures on the right. And again, we're seeing pretty similar patterns across all three, where for the most part, the adult and child populations are fairly stable across the 2010, 11, and 12 baseline years in terms of numbers of individuals or proportions of individuals who aren't utilizing services. And then in 2014, we see a spike, in particular in the populations that have adults, so that general adult group and the EBD adult and child group. And we see similar patterns in both of the ACO attributed populations as well. And so those jumps in non-users sort of relate to the figures that we were looking at on the previous slide, where we're seeing general declines in utilization among those groups in particular that have adults in them. So one of the other things that we started to look at was expenditure in certain categories of service. There's a more comprehensive table in the report, and I'm happy to direct you to that for additional information if you're interested. But this slide sort of extracts the 5 categories of service that comprise the majority of ACO total cost of care expenditure. This is really about 85 to 90% of expenditure for all 3 of these different groups in both years. You can see that generally we're seeing some decline in certain areas. We're seeing sort of minor increases in other areas. There's a little bit more detail in the report, and for the interest of time, since I'm coming up on my my mark, I won't go into it, but I will say that we took a further look at these categories of service, and we brought in that attribution subpopulation element as well, so adult, child, or ABD, adult and child. And you can read in the report that there were certain areas where we were seeing more notable decreases in expenditure among ACO attributed members than we were among their statewide analogs. So that's sort of an interesting thing of note that speaks to some of the work that's being done in the ACOs relative to what's going on overall. And the last one I'll point to is a quick analysis we did of expenditure outside of that total cost of care suite of services. For the most part, we can see here that there's a slight decline, as we were seeing in a lot of other areas, from 2012 to 2014 in per member per year expenditure in the non-total cost of care services that exclude pharmacy, which is the top table, and then the bottom table shows the same sort of analysis looking at pharmacy only. This was something that we wanted to look at just to see if, as a result of the total cost of care being more defined, whether or not there was any shifting of utilization from the total cost of care services to the non-total cost of care services. We're really not seeing much evidence of that based on the first year of data, but it's certainly something we'll continue to watch. So in summary, I think we can boil this down to a couple of high-level points before we go on. We saw an influx of beneficiaries who were newly eligible for Medicaid. We also saw a greater proportion of low-utilizing beneficiaries, and these all impacted the average cost of care per member in 2014 relative to the baseline years. We also observed some decreases in utilization across a variety of service categories. These also contributed to lower per member spending in 2014 relative to the baseline year. We will continue to analyze these trends following the second and third performance years of the program. And I think, much as Kelly and Richard were saying, we really need additional data to fully understand the impact of this model. But we look forward to having the year 2 results in the next couple of months. And I'll also say really quickly, the next couple of slides are the sort of analogous measure slides to those that Kelly presented on the commercial program, but since I've used up all my time, I won't say anything more about these, but they are there for your reference. With that, I will stop.
Thanks so much, Alicia. And we'll have time to ask questions at the end of the session. So it looks like we're going next to the presentation from CHAC, right? So this would be Kate?
Yes.
Okay.
So I'd like you to skip ahead to slide 31, please. Great. So I was asked to speak a little bit about what the work of the ACOs really is, and I'm the Director of Informatics for CHAC. And I want to talk a little bit about the work that CHAC did, especially in 2014 and 2015. I want to reiterate the point that Richard keeps making, that this is a pilot program and is a learning experience, and we have been learning as fast as we can learn for the past 2-3 years now, and so we're continuing to learn. But I want to tell about some of the things that we did. So CHAC really has focused on quality, on listening to our physicians and our clinicians, and working to improve our network collaborations. And sort of our overall mindset is that that's what we need to get right, and total cost of care will follow. So really what we did in our early year, 2014, is we began our CHAC Clinical Committee. This is a very grassroots group of somewhat feisty clinicians from all of the health centers. We've got quality folks. They meet bi-monthly, and they are sort of the lifeblood of what CHAC is. They began by developing some evidence-based guidelines in 2014. We did 4 of them in 2014, COPD, congestive heart failure, diabetes, and falls risk assessment. And they worked hard scanning the literature out there, working in small groups with their partners at hospitals and elsewhere in our network, and really wrote guidelines that they could believe in. And as you'll see in 2015, a lot of what we did was we implemented those 2014 guidelines through training, through conversation of what worked, what was working, what wasn't working. And so that was really a major initiative, and it's the first time our health centers have worked together to do anything quite like that. So we're very proud of that work. Also in 2014, we spent a long time engaging our community partners. We have all of our home health agencies and our behavioral health providers, mental health centers, and the specialized service agencies within our network as well. And so, as well as several hospitals are in our network. And so we spent a lot of time recruiting them in our network and recruiting them onto our committees and figuring out ways of working more closely with them. We also leaned heavily, CHAC does not have its own analytic system to date. We leaned very heavily on the Blueprint practice profiles. We did a lot of work consolidating them, figuring out who our highest performers were for different measures, and having conversations about what we could learn from those highest performers. So that was our work in 2014. In 2015, again, I'm going to talk about our clinical committee again, and we roped in with our clinical committee. We also have an operations committee of like practice manager, COO type folks from our network practices, the folks who get stuff done once the clinical committee sets the path. And we had a major initiative this past year in 2015 around doing plan, do, study, act cycles. And so each practice picked something that they wanted to work on. We tried to guide them to something that had something to do with the clinical quality measures that we would be graded upon. We thought that would be a nice thing, and many of them complied with that desire of ours. And we spent several meetings in which they worked through plan, do, study, act cycles, and they had the conversations. And for some of them, coming to our meetings where they had the operations person and the clinical person from the single health center actually having carved out time to talk about these things is when those conversations happened. They could have happened at the health center themselves, but coming together for the discrete purpose of doing this galvanized that, which was great. As I said, we implemented our 2014 guidelines, and we developed 2 more guidelines, which in 2016 we are just beginning our implementation of. We also, I talked about how we engaged our community partners in 2014. In 2015, we really were able to articulate a vision of how we might work together, which, as some of you know, is a document that we call the 10 points, and I have them on a later slide just for everyone's reference. But that was really sort of how we felt, what we felt was the root, or what we felt transformation should look like. We had something that we called the Data Roadshow also that we launched in 2015. So that was the data that we pulled for our chart abstraction data for our ACO quality reporting in the beginning months of 2015. And we spent a long time figuring out how to put that into its most actionable form and presenting it to each of our health centers. And our very small staff went out on the road last summer to all of the health centers, presenting that data, talking with them about, for the diabetes core control measure, is it that you're not screening enough folks, or is it that you're screening the folks but their diabetes is still out of control, and what can we do to fix that? So that was what we called the Data Roadshow. It was a big hit. The folks loved seeing their data. And so we used that in conjunction still with the Blueprint Practice Profile. We also in 2015 launched a remote monitoring initiative. This is something that we did with our Medicare population, but I thought I'd mention it because it was still a major initiative in 2015, an initiative that we launched because of data that we were seeing that showed that we could improve some of our transitions and get folks so they don't get readmitted to the hospitals with more case management and remote monitoring. So that's summary of our initiatives in 2014 and 15. In 2016, if I were doing this slide for that, I would be talking about patient ping and the event notification work we're doing that we're very excited about. But you'll see that slide next year. So I want to do a deeper dive into what some of this quality improvement work looks like at the practices. And this is a result of one of those PDSA cycles that we worked with one of our largest SQHCs around improving diabetes, around identifying patients identified as being in poor control for diabetes or having no tests. And so this health center had multiple sites. We learned through this PDSA work that that each of the sites kind of had different issues that needed to be improved. So it's not just you work at the organization level, it's really working at the site level or with the provider. At one of the site that did not show improvement, Site 2, we learned that it actually, the screenings were happening, but how the lab tech was entering it into the system invalidated the results. So they had to do a lot of re-entering. But it was something that was an important thing to learn, and so that has been corrected. We did other PDSA cycles at other sites around depression screening, around cervical cancer screening, and I think we did some adolescent well-child visit ones as well, but this is the one I wanted to show. We're very proud. This is, so moving to slide 33. This is late breaking. I just pulled this data together last week from our ACO quality reporting that we just completed for 2015 and just submitted. We are very proud to see that we have improved. These are all of our clinical quality measures. So this isn't the claims-based measures. We're not going to get our final breakdown of 2015 claims-based measures until probably August sometime. These are the clinical measures, and these are the clinical measures that are the ones that apply to more than one of our payers. So if a measure applied to both Medicare and Medicaid, I put it on this list, or Medicaid and commercial, I put it on this list. This is not me just cherry-picking the 6 measures that we improved on. I was pleased once I put them on the table to see that there's improvement in all of them. And I will say, though, that the diabetes poor control, although it is improvement, it is not statistically significant. But the other ones we do believe are all statistically significant improvement. So we know what the numbers are. Now my staff is analyzing, trying to figure out what is the root of the improvement. Is it that more people were screened? Is it that people are, like for tobacco screening, are we just asking the question more, or do we actually have more non-smokers amongst the mix? What is it different for different health centers? What is actionable about that? And so that will be the data roadshow that we're going to be doing this coming summer. So I'm eager to see the results. I'm also eager to see, we have, for some of the measures, it appeared that we had more patients who were in the denominator in 2015 than were in 2014 because they were coming in for care. So was that could that be because they are no longer, is that because of the expansion, Medicaid expansion, and because of the, they're now a year on the exchange and they're actually coming in to seek care for the more mundane things? I don't know the answer to that, but that's something that we're looking at. So the last 2 slides, I just wanted to put in the 10 points to transform the healthcare system. Why not share that with everyone? But really, the reason I added this was it's about how, as a network, we think we can work together, and it's the vision that we want to see in the state and what CHAC is moving towards to the extent that we can. And the last slide is some preliminary, very preliminary results from the remote monitoring program that we're doing with our Medicare population. We chose to do remote monitoring because our data around congestive heart failure that we get from Medicare and ED visits that we get from Medicare show that that might be areas in which we could show improvement. And we launched an initiative around remote monitoring, also in partnership with one of our home health agencies who's staffing this for us, to enroll patients onto this program and to try and connect them with care that they need before they go to the hospital. And so some preliminary data, and I will say that this is data from last fall, so I'm eager to to see my next bit of this data, is showing a preliminary reduction in admits per 1,000 for the folks that are in this program. So far it is looking promising. I have not seen my end of year 2015 data yet, and I'm eagerly awaiting it. So that's what I want to say about some of the work that CHAC is doing.
Thank you. And then our final presenter is Rick from Health First.
All right, so I'm brief, which is good. I'm Rick Shumlin, the Clinical Quality Director for Health First. So next slide. I was just asked to summarize briefly sort of our findings in our quality initiative. So this is our findings from 2014 to 2015. We improved in 4 out of 6. Again, these are the same clinical quality measures that Kate just said, the ones that we data abstracted on. The 2 that we decreased on are both ones that we already are pretty high performing on anyways, and the first one is not statistically significant, and we don't believe the second one is either. You can see in general we're making some gradual improvements across the board. So I hit the next slide. And this is a comparison and chart from where we are 2014 to 2015. You can see on the right is the HEDIS benchmarks there. So the top 6 measures are the ones that actually overlapped from 2014 to 2015, which is really helpful. The bottom 4 are the ones that were added for 2015, and one of the difficulties our practices often have is it feels like they're looking at lots of different measures all the time, and they feel like the playing field is changing. And this sort of demonstrated that to them when we showed them data, and they said, well, we have nothing to compare it to because it's a new measure. So that's essentially correct. But you can see one of the top 2, the immunizations and the pediatric weight assessment, are the 2 that we decreased on. Pediatric weight assessment, we're already above the 90th percentile, and immunizations, we are very close to the 90th percentile. And there are some issues that I don't know if this committee's talked about, but in the quality measures committee that was before this, and as they talked about some of the limitations of the 10 combination immunization measure. If immunization is not available from the state, for example, it makes it very difficult to meet that measure. Next slide. This is just a sample of the practice report card that we use as we go around each practice. It's sort of a multi-step process, and that's one of the things that we would like to improve, and I'm sure CHAC and OneCare feel the same. We get our data collection from our data abstractions together in February and get it back to you folks in April or May as quick as we can. We don't get the claims-based data for the payment measures until, like Kate said, until August. There's a significant lag. We oftentimes don't get what the measures for the next year are going to be until May or June of that year, sometimes later. So there are times where we're saying to folks, here's what we have been grading you on for the last 9 months, and we can't tell you how you did until you're 10 months into the next year, at which point we'll tell you what you need to improve on for the next 2 months to try to bring these numbers up. So it's a little bit of a shell game in terms of what the numbers actually mean. But we do it as best we can. So the data abstraction is probably the best measure we have at the practice level, since our practices are involved in the data abstraction itself. So we can bring the data to them quickly after they abstract and say, here's where you are. So each practice gets a report card like this that measures shows where they are in the current year, where they were the previous year, how they compare to the average across our network, across collaborative physicians, and how that compares to the 90th percentile. And next slide. And we just put on a graph so they can see where they're meeting. And this is compared to the VCP average, just so you can see if they're above or below performance for our network. Next slide. This is my last slide. I told you I'd be nice and quick and brief for you. So we have, we represent independent practices, and as you know, independent practices are independent generally for a reason. They don't like to do things the same way. So in some ways, it makes it more challenging than folks who have sort of more infrastructure, or people who have more, bigger groups. We don't have that, unfortunately. We have, 23 or 26 very independent-minded physicians who do things their own way. So the basis of our quality improvement is really practice-based. Our quality manager goes and meets with them on a regular basis throughout the year and says, okay, well, here's your data, here's how you can rate everyone else. Physicians by nature tend to be high achievers, and no one likes to be average. They all like to be above average. So when we say, here's how you are compared to the person down the street, they tend to want to improve that somehow. And so what we do is we present their practice report card. We do, like CHAC, we take we get a lot of information from the Blueprint practice profiles. We aggregate that for just our networks, get all the individual practice profiles, and we can show how they compare across the Blueprint, which is great. We have a quality improvement committee made up of physicians across specialties and across the state that we sit together and talk about what our priorities are, what we want to work on. We review all of the data for that. We identify the high-performing practices. Our quality manager goes and talks about workflows, and then we present that to the low-performing practices to try to figure out what what they can do. Oftentimes with independent practices, workflows are so dramatically different. Office structures completely are different. Some people don't even have nurses. Some have one nurse who answers the phone. It's just very different. So workflows often don't translate directly from place to place. Everyone has a different EHR as well, which makes some work better than others, and it creates additional challenges. I think our biggest limitations really are the lack of data. I'm sure Kate will probably agree as well that not getting the claims-based data back until more than halfway through the year makes it very difficult to implement any change significantly in the measures that actually result in potentially some shared savings. So that's frustrating, and probably the biggest problem we have is they feel like data is coming in at inopportune times. And as I know you've heard, but I make this plug every time in the committee, data abstraction manually from charts is time-consuming, it's labor-intensive, it's partially subjective, it's just not a great process. So anything we can do to get rid of data abstraction and get quantified data out of an EHR is a step in the right direction.
Andrew, can I just chime in?
Yeah, sure. Go ahead, Kelly.
Well, just one quick thing on the data part, but this is a learning effort between the ACOs and Blue Cross. We're actually looking at giving the quality data earlier in the year, and I know we look because our claims processes and data is pretty complete after 3 months instead of 6. So that's one thing that as we all try to say how to make things better, we're looking, it won't be official reports, but it'll be guiding. So is there a huge gap of where something is? So we haven't rolled that out yet. I know we were just talking about it, but our data is there, even though it's not complete. Medicaid was looking at it, or DEVA was looking at it as well. So that's something just showing us working together in process improvement.
Fantastic. Thank you.
Okay, well, thank you to all the presenters. We're going to take questions now. I think we'll start with the folks in the room just to make this easy. Those on the phone, we're not going to forget about you. Remember, if you want to ask a question, click on the raised hand icon, and the folks who are running the webinar will call on you one at a time. We still have a good amount of time for questions and discussion, so I am going to ask, though, one question, if you have a question or one comment, and try to be respectful of everybody else so we can get as many in as possible. Yeah.
I am curious about slide 18 on the presentation that was given by Lisa. And it's the daughter of the slide with cost per member year. And I understood the result going across roads. But I wondered if you could give us the take-home message for going down the column, so that when you compare the cost between chaplain care and other, which I assume the other is the non-attributed members, the non-attributed have lower costs in all of the columns except for the last one. So I'm kind of curious what the take-home is there.
I don't think we spent too much time trying to draw comparisons between those three groups in particular. One, given that there's different composition in terms of the actual ACO attributed population. For example, the distribution of the pediatric population is slightly different. The risk scores are not quite comparable. So it makes it a little bit difficult to compare the expenditure in those terms. And then in terms of why the group that is eligible for attribution that is not attributed has lower costs than the ACO groups, we didn't really do much analysis as to why that might be, and I won't speculate.
Can I just chime in? This is Abe from OneCare. I mean, one key difference is because of the way the attribution mechanism works, if you're a non-user and you're in that other group, you may have lower expenditures because that's why you weren't attributed to an ACO in the first place.
I thought that the physicians were attributed, not the actual individuals.
The beneficiaries come in based on where they seek care, but if they're not seeking care, they don't get attributed anywhere. So they're going to be in that other bucket.
But I thought you had to be eligible, you have to have had care in the last 10 months.
So in order to be attributed within a performance year, you have to have at least 10 months of eligibility within the performance year.
you can be attributed either based on your claims experience during the year or based on your PCP of record within the claims file.
And is that the same for the non-attributed? So for all people in similar studies, if you were not attributed to an ACO, it's that same criteria?
Mm-hmm.
I have a question about the quality adjuster for savings earned, and this would be slides 6 and 26. In the case of commercial, 56% quality point got a 75% earned, 67 got 85, and 89% got 100%, and then the Medicaid program, 46% of quality got 85%, and 63% of quality got 100%. So substantial differences there, and I don't recall what the design was.
I'll go quickly, and Alicia goes. So this is one of where we both had called a gate and ladder, so you had to hit different thresholds. Commercial was set higher in year one than Medicaid, so the 56% points got you in that 75th percentile band. It's the same methodology, but lower bands for Medicaid. So that's just where those fit in. Yeah. And was that changed?
Yes, it was changed. So in the first program year, the quality gate for the commercial program was 55% of total possible points, and for the Medicaid program, it was 35% of total possible points. The Medicaid gate was set lower in the first year because we had been looking at sort of overall Medicaid population experience on some of the payment measures based on the baseline period. We didn't really know which parts of the whole Medicaid population would end up being attributed, and there was concern that the quality threshold might be set too high in the first year. We did adjust the gate for the Medicaid program in the second year, so it's now comparable to that of the commercial program.
Great. That concerns me just to see we need to be able to say we expect the same care for our Medicare beneficiaries as we do for our commercial population.
Other questions? Oh, yeah.
Sean Scaffoldstead from the Agency of Human Services, for those folks on the phone. There's a slide, and I apologize, I don't know which number it is, but it's the one where you tried to sum up, which I totally appreciated, VM SSP summary.
Okay.
And that first bullet there talks about what beneficiaries, right? So that's exactly what
that's where we were seeing the bulk of the eligible folks.
Changes outside of this room just happened.
Right.
So is there any thought of adjusting any sort of our, whether it be a target or our expected numbers as a result of that?
I think
Or kind of put an adjustment on it?
the expansion population definitely posed a challenge to us methodologically in the first year because there wasn't really, I think it would have been difficult to know how to adjust for that population, not knowing whether the majority would be high utilizers or low utilizers, whether their general patterns would differ from the population that has previously been eligible for Medicaid. So I don't think there was any real effort to do an adjustment for that. I think another option would have been to sort of eliminate the expansion population altogether from inclusion in the program, but that wasn't something that was entertained when the program was being designed or when the methodology was being actuarially certified or approved by CMS. So I don't think we were going to make any sort of retro changes to how the methodology had been set up. And I think in terms of looking forward, the methodology is helpful because it utilizes a 3-year baseline period that rolls forward a year every year of the program. So now when we're looking at the 2015 program year, our baseline period will run from 11 to 13. If you look at some of the figures that show the 10, 11, 12, 14 trends, you see that something was probably happening between 12 and 14, even though we don't have it presented on the slides. And so that experience will be incorporated when determining what the expected expenditure will be for the 2015 And likewise, when we move into 16, the 14 performance year will be needed in the baseline. So some of these things will start to be addressed as we move forward, but it was a challenge in 14.
You can anticipate some continued membership churn through this year on data because redeterminations of eligibility for Medicaid were suspended and are going through that process this year. So I expect another one-time adjustment in that population this year.
Potentially hit Blue Cross too, because people will shift.
It'll hit all populations.
Yeah.
Yep. Time.
I'm sorry, just a little while. I go to that slide where we talk about that one slide that says expected, actual, there's your savings. It seems like this slide is saying, oh, there might be everything. But those things don't change. We still say that's your expected. I mean, that's the savings. So, I mean, I understand totally and appreciate the explanation for previously, but I can't help but think there's some consideration, and even going forward possibly, some sort of how do you build something like that in, or how can you build something like that in? Because the numbers aren't as cut and dry as you see them. I mean, it's just 3 numbers, expected, actual, savings. And you can see it's a little confusing. It's a little complicated, I should say.
It's definitely complicated. It spent us 18 months with the CMS actuaries to get approval for this design. So it's not just a state decision. It's the federal government took a very active part in terms of approving the methodologies, and it was a big challenge because of our small numbers. So I would not expect in a 3-year demo for the feds to agree to changes in methodology at this point, given where we are in the demo and the fact that they have their own evaluation process that we're going to be embarking on. Is that fair, Georgia?
Yes.
All right. Yeah, Mike.
When I look at this, and it's quite possible that I am misinterpreting it because my head is kind of spinning. But the anticipation, I think, when the expansion population came in, and was that there would be pent-up demand and you would see a significant uptick in utilization. And yet, when I look at the 2012-2014 comparison, I'm looking at page 23, but there are a couple other references on some other slides. It looks as though utilization was lower than anticipated. So, I just want to confirm that I'm interpreting that correctly.
I think one of the things that, I think it breaks it down pretty well on slide 18, where we're looking at sort of the different segments of the population. There's also a table in the longer report that looks at expenditure for the expansion folks relative to others. I think overall, when we look at the expenditure for the expansion folks relative to the folks who had original Medicaid eligibility, the expenditure was pretty comparable, but that's because the expansion group was comprised of those 2 segments where we've got sort of a subset that's really utilizing a lot of services, sort of illustrating that pent-up demand that was expected, but the remainder of them weren't really utilizing many services. We don't see much evidence of them engaging very intensively with the healthcare system in 2014. We'll start to see, I think, more of that in 2015. Perhaps they'll start utilizing services in the 15 performance year that they didn't utilize in the 14 performance year. But it really was a blend of folks who are using a lot of services and folks who are using hardly any. And I think some other states have been seeing similar patterns as well. The expected experience for the expansion population was something that was difficult to model.
Okay, we'll take a question here. We should probably check in with folks on the web after that. Nothing? No?
Yeah.
Okay. Go ahead.
My name's Maura Graff. I work with Planned Parenthood of Northern New England. I think it was on slide 20 that you were talking about how these PMPM expenditure declines across categories can be attributed to the wonderful work that's being done by the ACO. I was just hoping
that you could elaborate that on a little bit and also talk about how we can attribute these declines to the work that's being done by the ACOs. I think, that's part of what we were trying to illustrate. There's a lot going on in 2014. It was a tricky year, really, to assess whether or not a program in its fledgling year is achieving the goals from the outset. I think a lot of what we were seeing has to do with some of the shifts in the Medicaid population. We're seeing general downward trends in utilization, not just from baseline to 2014, but a little bit across that baseline period as well. And so there's some momentum coming into the 2014 performance year. But in terms of being able to talk about what the ACOs themselves were doing, that's why we were glad that the representatives from the ACOs were able to be here as part of this conversation today, because I think they're really best poised to speak to some of the interventions that they've got going on. I think we've also heard that, 2014, there was a lot happening, and it might not all have been fully set up in 2014, but a lot of the foundational work was happening, and it'll be interesting to see over the course of the next 2 program years how all of the work that they've been doing starts to manifest in some other results that we can take a look at. And I'll defer to the ACOs to see if they want to comment on anything else.
I think it's fair to say that there's not an easy answer to your question. I mean, we will never have the analytical power to finally determine all of the many levers that are causing these numbers to move around. I mean, there's always going to be some noise in this, and this is something in our industry that we struggled with for decades, trying to know how effective interventions are, because the population just moves a little bit differently each year. I mean, there's broad cycles of ups and downs that just come in and out of focus, and I think if we continue to look at the activity, though, as Rick and Kate did for us today, I mean, we can hopefully draw some confidence from the nature of the work that they're doing and the type of discipline that they're applying to their work to plan a change, look for a certain improvement, try to measure for that improvement. Hopefully all of those actions accumulate value over time.
I mean, it's a valid question, because the Medicaid ACOs weren't formed until September or October that year, something like that. I mean, so I do think it is. I think it really is a benchmark setting thing more than I think ACOs. I mean, I work for one. I think ACOs are doing a lot of good work, absolutely. But I think to say, ACOs, what change the ACOs make to achieve that savings in that year, when they didn't realize they were a Medicaid ACO until 10 months out of the year, I think is a little tricky to attribute savings from any specific program that anyone did that year, because they didn't exist.
The ACOs that were participating in the Medicaid program had formed in 2013 prior to the 2014 performance year, and I think there was also some benefit to be derived from the fact that the ACOs had been, or at least in the case of OneCare, had previously been participating in the Medicare program, so there was some prior experience operating as a network. So there was some of that.
Okay. This is Abe. Alicia sort of took the words out of my mouth. We were operating as an ACO in the Medicare Shared Savings Program in 2013, and I mean, as many know, you don't get as much differentiation between the way you deliver care between whether a patient is Medicaid or commercial or Medicare as you might think. It's not like you tailor the approach to any given population. So I think some things had started to move in that direction anyway. But I would also say that this is year 1 of a 3-year pilot that we're looking at. So, I mean, I think we should, to Andrew's point, there are some variations that happen year to year, but I think we should try to reserve whether we believe this was successful or not till we've seen a little more track record here.
I agree, and I think as a working group, it would be great if we could sort of be on the same page in terms of how we talk about the results and what they may imply.
I have a process question. My understanding was that after today's presentation, we would be soliciting, the Payment Models Work Group, would be soliciting additional questions that then we could have follow-up at our June meeting on. And I'm saying that in part because I have 9 questions, and some are kind of significant, like how do you explain the difference in the 3 ACOs results, and what were the costs and the ongoing, and like pretty meaty questions. And so I thought we were going to be soliciting written questions that could be categorized and answered
Well, if you've got a good meaty question, I'd suggest that you throw it out right now. I don't think we're going to be putting this back on the agenda in June. What I'm going to suggest instead is that we bring this back again. I think we're looking at probably the September timeframe when we have the year 2 results. I think it'll be a little bit easier for us to really dig in when we've got a second year of data. In the meantime, though, if you have questions for specific presenters, let's send them to those folks and they'll try to get them answered for you before the next meeting.
We didn't actually get the year 1 results till 6 months into year 3, despite them being promised. So I'll take the September with a grain of salt. But so the 2 main meaty questions are how to explain the difference between, and going to Julie's point on that slide where it really seems like the unattributed ones went down, and it doesn't seem like that's very important to other people, but following up on what Maura said, like, well, what did the ACOs do to arrive at savings if the unattributed people's costs were going down? But how does that factor into why was it only the Medicaid Shared Savings Program that had savings, not the commercial, not Medicare? So if someone could answer that in 7 minutes, great. But then the other question is, when people talk about savings, I tend to think about that in sort of a return on investment modality. And I think either the investment or the setup costs and the ongoing administrative costs of the ACOs, I'd be really interested in knowing if people have a handle on that and what that is, and then how you offset the savings. But, you know, since we're going forward in a non-shared savings modality where we're going to be giving the ACOs our Medicare, Medicaid, and commercial money, it would be nice to know how much of that money is going to be siphoned off for these administrative costs. So admin costs, comparison, 7 minutes. But I really did think, and I'm on the group that set this agenda, that we said we were going to be soliciting questions and that we'd get follow-up to.
Well, questions came before the meeting and they were distributed to the presenters so they had an opportunity to try to incorporate as many of them as they could into the presentation.
But we didn't get these materials till sometime on Friday to even ask questions about these materials.
Okay, well, we'll do our best. So does anybody want to try to respond quickly, any of the presenters, to any part of Steve's question?
I can just go very quickly in terms of the difference between Medicaid and commercial. I can't speak to Medicare. I haven't seen those reports. That's a completely different animal. But
who could speak to that?
The Medicare, I would think ACOs in terms of their performance. But I'll quickly get with the minute of the 7 minutes. The difference of savings, very at a high level of commercials, I said, our trend, or excuse me, the target and expected that year based on a premium that everyone agreed to, the Green Mountain Care Board, the ACOs, and us, but we had a new population, new benefits. There was not the historical 3-year benchmark that is what was used for Medicaid. So it was our all best attempts to set the appropriate benchmark, but we lost money on that population as well. You know, that was lost. So we saw the same across all populations is what I'm saying. So no one was kind of shocked if there was going to be savings or gains because this is a whole new population. There wasn't a solid benchmark, much like Medicaid had. So that's the explanation because it was based on the medical cost in the benefits. It wasn't based on actually, if you were attributed, what your historical would have been, which is what we're actually looking at for year 3. So we'd have a much more appropriate benchmark. So that's the difference of why Medicaid and commercial, if that's fair.
Yeah, I would also add to that, I think your comment that these results from year 1 weren't available until year 3, they were available and they were discussed at one of these meetings at some length. Those bumps, they were. So
yeah, but they weren't provided. They were not available to the people on the phone. They weren't mailed out with the materials.
Yes, because the presentation that was just given was actually from the presentation earlier. So I'll just leave it at that. I'm leaving soon, so I don't see much. But they were presented and there was a long discussion about the results.
Yeah, I can give you an email trail a mile long. No, Richard.
So there are, this is not, so if this is intra-agency stuff, like between Dale and Diva, there's another path for that.
Nah, I'm on the payment model work group. We're evaluating this. This is SIM. But
So we're about out of time for today. I don't think we had anybody from the general public, but I'm not positive who all is on the phone. So why don't we do this? Sue, you can send your questions to Kathy and I, and we'll make sure that they get out to the presenters, and we'll try to get you answers. September will be here quickly. We will have presentations in September on the year 2 results, and we'll make sure that any questions you didn't have answered between now and then, we take up then. Okay. So 1 minute for public comment. Is there anybody from the public? I don't know everybody's faces.
Joelle, there were no other questions.
There were no raised hands on the through the webinar. So I will probably forward one written question that came in just for clarification, and that's the end of that.
All right, if no comment, I guess we are adjourned.